Good morning, folks. It is indeed a great pleasure to be a part of the 19th Wadia Pediatric Surgery CME. I thank the organizers and also the chairpersons. Greetings to them. The topic that I have been given is the role of robotics in pediatric surgery. I would like to discuss the role that a robotic program can play in pediatric surgery and what are the various indications for which it is currently being used and what is the current status. So robotics in pediatric surgery, what is the current status? It basically, if you look at the historical background, the robotic Da Vinci system was introduced in 1999, 2000. 2001, the Nissen's fundoplication was done. The commonly performed procedures were incorporated into pediatric surgery by 2005-06. And now I think more than 70 different surgical techniques have been incorporated via the robotic technique. If you look at the first decade, the US was the major prime mover for the robotic program, with about 80% of the papers coming out from the United States, and the 80% of the installations were happening in US. Europe, Asia, Middle East were lagging behind significantly. So let's talk about the Da Vinci surgical system. What is the composition? The most commonly available, which we come across, is the surgeon's console, which is a stereo viewer with infrared sensor which are present. The pod controls are there, master foot controllers and foot pedals are available. The patient cart supports the instrument arms, the endoscopic arms, which is next to the patient itself. And then there's a vision cart, which is the heart of the system, which has the endoscope, the core processor, image processing with energy devices, insufflator, they're all included in the vision cart itself. And the surgical assistant role is very important. He sits next to the patient itself and becomes the eyes and ears of the surgeon itself, because surgeon is sitting some distance away from the patient itself. So just the history, in 1999, the Da Vinci system was introduced. Ironically, it was introduced or designed for heart surgeries. However, CTVS has not incorporated it at all, and it has fallen upon urologists and gynecologists and pediatric surgeons to take up the robotic system for our own use. The Da Vinci S system was introduced in 2006, which had an increased ease of handling and increased amplitude of arms and instruments, allowing for cross-quadrant access. The Da Vinci SI system, which is reasonably similar to the XI system currently available, is basically a dual console option with enhanced HD visions. And with the XI system introduced, it had more improvement in the imaging technology. It had also better energy devices, better instruments, including staplers and energy sources. So what are the advantages of robotic surgery in children? The various advantages I think everybody talks about: 3D vision, stereoscopic visualization, 7 degrees of freedom, motion scaling, operator-controlled camera movement, etc. Let's go over a few of those advantages. So the advantages of robotic, better visualization is by far one of the best advantages that you see. You get a 3D vision. 3D vision is available in laparoscopy, but it is much more cumbersome to use in laparoscopy. Here in robotic, 3D vision is actually a benefit. You can go for millimeter point precision. It also is associated with a 10x or 15x magnification, which can allow you to see even the smallest, minutest blood vessels. There is a great field of vision. You can go close and you get all the benefits of the magnification, or you can zoom out and get a bird's eye view. So you get the best of the both worlds, and you also have the a very stable visual field. I think all of us have struggled with the gradually drifting visual field because of a bored surgeon getting distracted. So camera in robotic surgery is in direct control of the surgeon, and once he fixes the camera, it stays there. The advantage of robotic is mechanical improvement, 7 degrees of freedom, just like an endo wrist, 7 degrees of freedom is available. There is less fulcrum effect, no tremors get passed on to the patient itself, and there is motion scaling, that is large movements of your arm are translated into a much smaller movement inside the patient and leading to much better outcomes. Stabilization of the instruments is another major advantage of robotic system. Small movements are in lab. The small movements are magnified because of the fulcrum effect. Small movements become magnified. However, there is motion scaling in robotic system, and you can have point precision or millimeter precision in robotic system. The needle or needle should come out exactly where you design it to come out. Improved ergonomics is also one of the big plus points for robotic system. You are sitting in a seated position, relaxed, which allows you to move. You're looking straight ahead. Washing up is not required. You can step out, move wherever you want to, whenever you want to, right? So that's one of the major advantages of robotic surgery is improved ergonomics. Senior surgeons who have just started robotic surgery believe that their surgical careers may be extended by another 10 years because of the ease of doing surgeries. There are limitations of robotic surgery in children. High cost is one of the major factors. Capital, maintenance, disposable, everything is costly. Lack of tactile or haptic feedback. And you need to be aware about the situation, what is happening, where. You have to always be on your toes. The larger size of instruments, 5 mm, 8 mm instruments are available. They are larger size as compared to smaller babies that we operate on. So that's one of the cons of robotic surgery. Robotic camera, 8 mm cameras are generally of the larger size. In laparoscopy, we usually commonly use 5 mm instruments, so a larger port size is required. Interport distance recommended is about 8 centimeter distance. With 2 port, the distance becomes 16 or 17 centimeter, which might be difficult to achieve in smaller children. So the disadvantage is cost is a major con of robotic surgery. The training cost, not only the surgeon does need to be trained, the team, the assistants all require training, and they need to stay with the robotic program for a significant length of time so that the benefits accrue. The instrument limitations, again, suction irrigations are not there. The assistant is always required to pass the sutures, pull out the needles, sometimes even cut the sutures, and instrument changes. You require all these things require assistance to be present, and each use of instrument is costly. Lack of tactile sensation or haptics is also one of the major disadvantages of robotic surgery. These are usually compensated by visual cues that surgeons get, non-tactile sensory cues that they get while doing robotic surgery, and it takes time to internalize these visual cues. Residents and surgeons, when they are operating with me, I find many of the residents are constantly, especially the newer people, they're constantly breaking the sutures because of this lack of internalizing the visual cues available. Then, because of the robot is a machine, it's a software and hardware, there is always a risk of mechanical failures. Redundancy is built in, and each instrument can only be used for 10 uses. So these are the safeguards which have been built in to allow for graceful performance degradation. It's not as if it cannot be used further. It can be used further, but they have capped it at 10 uses so as to allow the instruments, good quality instruments, to remain um, without degradation. Fault tolerances, system alerts, just-in-time maintenance have all been included as safeguards to prevent mechanical failure. There's limited area which is covered with each docking. You can, at the most, do 2 quadrants of the abdomen rather than the whole abdomen which is available in laparoscopy. So redocking may be required if you want to operate many areas. Let's say you're trying to do a total colectomy with robotic surgery, you might require to redock twice or thrice. So factor determining the feasibility of robotic surgery in pediatric patient, right? So, so 2 main commonly used criteria are weight and body dimensions are used to determine whether the robot can be used or whether the robotic assistance is feasible in pediatric patient. Weight generally is being found, but found that more than 3 kg generally with difficulty, it can usually be done safely. However, less than 3 kg, people agree that it is extremely difficult to do in children less than 3 kgs. Body dimensions have also been used as a surrogate to determine the feasibility of robotic procedure in children. Less than 13 centimeter anterior superior iliac spine distance, or less than 15 centimeter pubis to xiphoid distance are precursor or can tell us about robotic instrument collisions. So how are we overcoming them? How are we overcoming the challenges of a small patient in the with a system which is designed for adults? So one of the factors that we can use is trocar depth. There is something known as a remote center which has to be present at the level of the abdominal wall musculature. However, that leads to about 4-5 centimeters of the trocar projecting inside the patient itself. Just carefully pulling out the remote center outside the abdomen can buy us an extra 1.5 to 2 centimeters of extra maneuverability in children. So what are the various cheats that we use to use the robotic surgery, robotic instrument in children? So as I talked about, careful or calculated manipulation of the remote center is one of the common cheats that we pediatric surgeons use. In children, triangulation of robotic ports can also be used whenever feasible. So the recommendation is ports are supposed to be on a single straight line. However, a careful triangulation of the robotic ports can also be used so as to allow, get adequate distance as well as avoid bony landmarks. Then carefully decreasing the distance between port sites in children. I generally use the formula 1 centimeter per kilogram of birth weight of the child that is used for any child more than 3 kgs till he reaches about 6-7 kgs. Then we can go ahead with the normal adequate port placements. Simple lateral adjustment of the trocars can also improve mobility of the instrument arm, and sometimes with non-standard port placements you can proceed without targeting. So these are the various cheats that we use or technical modifications we use in robotics in children. So just as an example, here, not only is the optic port placed below the umbilicus for a colorectal cyst, there's a gentle triangulation has been achieved so as to get adequate distance between the ports to allow for adequate space. And one of the remote centers from the left side has been pulled out so as to allow for extra distance for manipulation. So instead of a straight line, we've gone ahead and done a triangulation, pulling it out a little bit. So these kind of modification or cheats as such can be used. The companies are also coming up with various innovative new technologies like Senhance or Verseus robotic surgical system, which can operate on cavities as small as 100 ml. which will be a big boon for pediatric robotic surgery. Da Vinci has also come out with a single port robotic system where one single 2.5 centimeter port can be placed and all the instrument, the camera, everything goes through that single port and can be manipulated through that single port to allow for it's the use of robotic surgery in pediatric patients. Now let's talk about the learning curve in pediatric robotic surgery. That's an important in my heart. That is one of the major pluses why pediatric surgeons should adopt robotic surgery. There is definitely a shorter learning curve than laparoscopy, and the major factor is basically because of the intuitive symmetric motion of the robotic system, which is consistent with surgeon's arm. So if you have to move something to the right, you move the arm to the right, as which is opposite in, let's say, a laparoscopy. So coming on to the learning curve in laparoscopy, if you've not been exposed to laparoscopy during your training years, I believe you take about 6 to 7 years with dedication. If you exposure, that is probably a learning curve if you're trying to learn laparoscopy. If you have been exposed during training, you still take about 4 to 5 years to learn laparoscopy. And so traditional laparoscopy generally entails a longer, a more difficult learning curve, and it requires more dexterity to work with rigid instruments on a flat screen with a lack of deep sensations. So why is this learning curve of laparoscopy, why do I call it crippling? Because we had very many advantages. The advantages we had were good fundamental fallback of open traditional or traditional methods of doing surgeries. We had good backup of open surgery, and then we moved to laparoscopic surgery. And at the time when we were trying to learn laparoscopy, the society and the patient both accepted open procedure. Lap was believed to be a cherry on the top rather than the main mode of treatment, right? However, if we look at our resident at this time, the training at this time, the big three, let's say pyeloplasty, choroidal cyst, and reimplantation, our residents would not have seen open pyeloplasty or choroidal cyst during their training. 80% of the reimplantation are being done by laparoscopy. So their backing of the open or traditional approach is on a shaky ground. So the residents or young surgeons are basically in a double bind. The residents are unexposed to these open procedures, especially the big three or the bread and butter of pediatric robotic surgery. And the society and patients are also not accepting open procedures at all. Even in our centers, obviously in different departments, hepatectomy, Whipples, esophagectomy are all being done laparoscopically. So how can we expect patients to accept that our residents will do pyeloplasty or choroidal cysts by open procedure when they pass out and go into practice? So here is where the role of robotics comes in. The top of the learning curve in robotics is reached after 10 to 20 procedures performed for the same pathology in robotics. Learning curve for one procedure is generally carried forward partially, at least, to the other procedure. And for technically novice surgeons, experience an early and persistent enabling effect by the use of robotic procedures, right? So they have an early and persistent enabling effect. So robotic surgery will eliminate early learning curve for novice surgeon, but it may not provide any other advantage for experienced laparoscopic surgeon as far as learning curve is concerned. So when experienced laparoscopic surgeons say robotic is useless, it basically I can do all the procedures via laparoscopy, they are absolutely right. They can obviously do those procedures laparoscopically, but we have to think about the learning curve in total as a big picture. So lap experience is definitely a plus for robotic surgery, but is not a must. Many principles are directly ported from laparoscopy onto the robotic surgery. Good lab foundation is definitely helpful. Now, coming on to the reported pediatric robotic procedures, the big three or big four basically depends on pyeloplasty, ureteric reimplantation, coracoid cyst, and fundoplication. These are the most common indications for which we do robotic surgery. However, the indications for robotic surgery in pediatric patient has expanded to more than 70 odd procedures. It has been used successfully for many procedures in pediatric patients. What does the evidence say? Now, evidence in surgical field is different from evidence-based medicine. In evidence-based medicine, the evidence is generally front-loaded, where once the evidence comes, the practice follows. That is how the medical branches go. However, in surgery, the evidence is usually backloaded. The procedure gets incorporated, the evidence is generated, and then the evidence comes decades later that yes, this procedure is useful or is not very useful. So that evidence is backloaded, the incorporation is the incorporation of the surgical procedure itself is front-loaded. So if you look at the evidence, 80% of the surgeries being performed worldwide is pediatric urological anomalies with pediatric tumor, pediatric thoracic surgery, and abdominal surgical pathology, comprising the rest of the 20% of the procedures being done by robot procedures. If you look at the evidence for robotic surgery is available only limited to pyeloplasty for UPG obstruction and ureteral reimplantation according to Lesch-Krieger technique. That is where the evidence actually exists to recommend use of robot in pediatric patients. So, outcome of robotic pyeloplasty in children, the success rate has been about 90 to 100%. The shorter hospital stays have been seen, less use of medication and pain management. However, longer operating time as compared to both laparoscopy and open is seen. Robot-assisted laparoscopic single-post pyeloplasty has been shown to be feasible. We are progressing towards hidden incision endoscopic techniques for robotic, where non-standard port placements in hidden areas are being used to allow for better cosmesis. Robotic ureteric reimplantation is also one of the common urological procedures being performed. It can be done via the intravesical or transvesical adaptations of Cohen cross-trigonal reimplantation. We use the extravesical adaptation of Lesch-Krieger reimplantation very commonly. So, looking at the literature, outcome of robotic-assisted ureteric reimplantation, the reflux resolution rates varies between 72 to 100%, and overall complication rate has varied between 0 to 40%, depending on which paper you look at. So, if you look at the systematic review and meta-analysis, the success of robot-assisted is significantly lower, even at the present moment, lower than laparoscopy. And the robot-assisted is generally of a longer duration surgery as compared to laparoscopy, and however, the complication rate are comparable between robot and laparoscopy. What are the common complications? Urinary retention, transient ureteral obstruction, sometimes ureteral injuries might also be seen. Coming on to coledochal cyst is another one of the procedures that is commonly performed. If you look at the literature has very sparse literature with case reports of 1 or 2 cases. Now, recently literature is coming with larger case series of 36 more than 20 cases. They have demonstrated that it is reasonably safe, can be done. Long-term results are still awaited. So the indications for robotic-assisted surgery in pediatric surgery presenting with hepatobiliary diseases remain relatively scarce. Coming on to oncological surgeries, especially nephrectomy, current gold standard is definitely open surgical procedure. Robotic assistant can be valuable in complex procedure like partial nephrectomy. However, because of oncological principles, the role of robotic pediatric surgery in pediatric tumor is considered a safe option only in highly selected cases. So, with the current advantages of robotic surgery, its disadvantages also there. But however, for training, I think the lack of learning curve of robotic surgery as compared to laparoscopic surgery, it is a compelling argument for us to consider having a robotic program in pediatric surgery departments. The surgical training should also be tailored for robotic training for our residents. It basically, if you look at the surgical training in robotic, it basically boils down to three distinct phases, where the first phase is basically a perceptual understanding or a cognitive understanding of the instrument that you're using, the robotic system that we are using. And this is followed by a guided learning where the segmental steps are increasingly more complex steps are being performed by the residents, including endosuturing, knot tying, or dissection of certain thing. And this can be followed given adequate exposure to an autonomous stage where those residents can do the procedures or trainees can do the procedures independently. So in the end, robot-assisted procedures definitely have a role to play in pediatric surgery. Cost, large size of instruments, difficulty that we face in smaller patients are major cons for robotic surgery. However, it does take care of the crippling learning curve of laparoscopy. Endosuturing, vision, ergonomics are a significant plus. Exciting advances are coming, new robots are coming, and it will become more universally available, right? And evidence for various robotic procedures are always backloaded in surgery. It will definitely follow especially for the more commonly performed procedures. Thank you. I'll be happy to answer any questions.